again for coming out today. It's kind of one of these days that are it's a little icy out. So if you remember a couple months ago, we had a presentation on falls. This would be a good time to remember what you learned at that Lunch and Learn, right? So anyway, thank you for coming. It's good to see some repeat faces here. So we will, at the end, tell you about our next Lunch and Learn. So be sure and sign up for that. So without further ado, I will introduce Dr. Gregory Kosters. He is a physician over at AMG Sibley and also here at the hospital. So, Dr. Kosters, the floor is yours.
All right, thank you. So I gotta get rid of that mug shot. It looks like a wanted poster or something. First of all, there's somebody back here I know. Dr. Larry Foster from Worthington is here. He and I knew each other when we were just little doctors, and so it's we both are a little more gray and maybe have a little but anyway, it's good to see you here. That's good. So, all right, we're going to talk today. At least I am anyway for a while. Talk about antibiotic stewardship. Now that's a big word and that sort of thing, but you know, increasingly we're getting in situations, and I remember when I first started practice in the 1980s, I had mothers with little kids leaving my office pissed because I didn't give their kids an antibiotic. And so there may be some of you recently who have seen a doctor or provider and you thought you needed an antibiotic and you didn't get one. And I know because sometimes I'll see people a couple of weeks later for another reason. They say, yeah, I saw so-and-so and I didn't get an antibiotic. Well, I'm going to probably stick up for whoever didn't give you the antibiotic today. We're going to talk about that, and we're going to talk about why, and we're going to talk about maybe some things we can do in the future to help, okay? Now, I'm a little bit of a history buff. I like history, so we're probably going to talk about history a little bit as well. But for the purposes of the talk today, when I say an antibiotic, I'm talking about an antibacterial medicine, okay? We've got different antibiotics nowadays. We've got antivirals that we use for certain virus infections. We've got medicines for, certain types of hepatitis, HIV, recurrent cold sores, shingles. We've got antibiotics that can kill some viruses. We've got antibiotics like fluconazole that can kill yeast and fungus. We've got some very strong antibiotics when people are very sick that are against certain yeast infections in the bloodstream. But for the purposes of talking today, I'm going to be speaking mostly about those agents that are designed to kill bacteria. So when we talk about antibiotic stewardship, what are we talking about? We're talking about the efforts of doctors' offices, clinics, nursing homes, hospitals, all other kind of health settings to ensure that, number one, that antibiotics are used only when they're necessary, okay? Because the inappropriate use has gotten us into some trouble. And so we're trying to limit that nowadays. So we want to use antibiotics only when necessary. And when antibiotics are necessary or when they're appropriate, we want to make sure, number one, we get the right antibiotic at the right dose. We want to prescribe it at the right time. And we want to make sure it's given for the right length of time. All those things are very important, okay? And you know what? You play a role in this, and we're going to get into that a little bit later as well. Now, getting to the history of it, it's very interesting. If you look throughout the history, but antibiotics, a lot of the antibiotics we have against bacterial agents have come from yeast or fungus or other things. Back, if we look about 2,000 years ago, there were practices of making poultices out of moldy bread back in Egypt, Greece, China, and Serbia. Okay? So even back then, long before Alexander Fleming, I'm jumping ahead of myself here, but if we look Papyrus, if you remember what papyrus is, those are ancient writings, mostly from the Middle East, and Egypt and Samaria and those type of places. As early as 1550 BC, archaeologists have unearthed medical documents that included moldy bread and medicinal soil. Now, what's medicinal soil? Medicinal soil is dirt or a substance we get because, for example, in this part of the United States, there is a predominant soil mold called actinomyces that helps to make soil more fertile. It breaks down elements in the soil so that our crops can use them and other plants can use the nutrients. And so that's also a mold. So it gets back into this moldy bread kind of concept. Plus, in the soil, there are things like borax, sulfur compounds, and that sort of thing. And back years ago, people were concocting things, and they found out that, especially in open wounds and open sores and bacterial infections, that these things helped and would treat it and clear it. Anglo-Saxon, getting into another part, that's more of the Northwest European, British Isles type area. 1,000 years ago, they had a recipe that has been shown to kill MRSA. Now, MRSA is the methicillin-resistant staph that we see. It's one of the superbugs we talk about. They had a recipe back then that is effective against that. So, wow, this hasn't been going on just in the last 100 years. However, prior to the antibiotics, we didn't have any good processes for concentrating those substances. We didn't know why mold would work. We just knew that it would, or they knew that it would. As science evolved, we got to the point where we found out what is it in penicillium mold that kills bacteria. Oh, well, we can take that, we can concentrate it, we can purify it and make it more effective. Prior to our ability to do that, in 1900, pneumonia, tuberculosis, diphtheria, cholera, and other intestinal infections caused 1/3 of all deaths. Now we talk about cardiovascular disease because we're living long enough now to get heart attacks and strokes. Back then, the life expectancy was much shorter. I think in 1900s, the life expectancy, at least on this side of the Atlantic Ocean, was about 48 years of age on average. Now, there were definitely people that lived longer, but a lot of people died younger. And the reason our life expectancy was shorter was that 1 out of every 20 infants died before their first birthday. 1 out of every 20 because of bacteria infections. Nowadays, it's about 3.5 out of every 1,000 in the United States, at least. There are some, and we're not the best. There are better countries, there are worse countries. So, because of our ability to identify these substances that can kill bacteria, we've been able to take care of a lot of these things that used to kill human beings. There was a Dr. Paul Ehrlich who, in 1909, ended up developing a compound called salvarsan. It was an arsenic-based compound. It was also called Compound 606. Sounds like something out of James Bond movie, doesn't it? Mr. Bond, you have to secure the supply of Compound 606 that was stolen from, and long live the Queen. So, but anyway, this was used to treat syphilis. He was actually looking for a cure for African sleeping sickness. I don't know if some of you remember in high school the tsetse fly. There's a bug called trypanosomiasis disease. It's a spirochete. And it's kind of a cousin of syphilis. Well, he was trying to find a cure for sleeping sickness and serendipitously found this treatment for syphilis. Unfortunately, because it was an arsenic-based compound, it had an incredible amount of side effects. Okay? Now we get to Alexander Fleming. In 1928, what happened is they were trying to find, they were culturing out staph and strep bacteria in a lab And they were doing experiments on staph and strep bacteria, okay? What happened is he stuck some of those plates in his drawer and went on vacation. When he came back, he had forgotten about those, so he pulled them out and he noticed that there was mold growing in those petri dishes. And where the mold was growing, there was a zone around those mold colonies where there was no bacteria. So he wrote his findings down, and he says, this may be something here. However, it was kind of put off to the side, and it wasn't until later that we were able to identify things. And then it took about 12 years before we really started using penicillin, okay? So there was a guy, Gerhard Domek, over in what is now Poland, over in Europe, he was using sulfonamides. They were, you know, you don't want to be a rat in a laboratory, but they were giving blood poisoning to mice, and so he discovered sulfonamide would cure that blood poisoning. So really, sulfa antibiotics were the very first really to be used in the early 30s as a widespread treatment. But later on, because of expense and because of ease of manufacturing, penicillins actually became more widespread, thanks to Oxford University in England, because they're the ones who took Fleming's mold and discovered what it was in the penicillium mold that killed bacteria. And they were able to purify it, concentrate it, develop it into something that could be used by people. So they purified it, and so then in the early 40s we started using penicillin mold. And then Dr. Waxman, most of these doctors aren't medical doctors, they were PhDs. But streptomycin then in 1944 was the first breakthrough for tuberculosis, which was actually quite widespread throughout the world, still is. So basically during the 20th century, especially since the 40s, we've now got an answer to all these bacterial problems. So the use of antibiotics just ballooned, okay? And I've got a little graph right here that we're going to show, but resistance emerged pretty rapidly. You know, if you think about it, if you have an infection and you say you have 50 million bacteria in this infection on your arm, when we give you an antibiotic, it's not going to kill 100% of the bacteria, because bacteria grow so fast and change their genetic material so fast that sometimes they get little mistakes in the DNA, okay? Those mistakes are what we call mutations. And sometimes they'll have a mutation where they will make an enzyme, say, that inactivates penicillin. So what happens is I kill 95 or 99.9% even of those bacteria with the antibiotic. Now your immune system has to finish the job, okay? And your immune system has to clean up the mess. That's why people with bad immune systems we treat a little differently, but that's a talk for another day. But anyway, so all those little babies that survive, they're all resistant. So all their offspring, our chances are they're going to be resistant. So it didn't take long for resistance to start emerging. And it's also estimated that there should be 1 million in there, okay? There have been, since we started commercially producing antibiotics in the 1930s, over 600 million metric tons of antibiotics have been produced, okay? So that's not just regular tons. It brings me back to an episode of the Beverly Hillbillies. You know, when Uncle Jed got a check for the oil that he found, you know, the bubbling crude. And then he and Granny were talking, and he says to Granny, but these aren't regular dollars. He couldn't figure it out. So Granny says, what do you mean? Well, these aren't regular dollars. These are $1 million. And Uncle Jed didn't know he didn't know $1 million was worth anything. So this really should not just be regular metric tons That's 600 million metric tons. And we're gonna talk about that in a minute too, because the Earth's environment is now saturated with antibiotics, okay? If I put you on an antibiotic, what happens to that antibiotic? Our body metabolizes some of it.
Yep.
Our body uses it, some of it.
Excretes the rest.
Excretes the rest. How do we excrete the rest? We all know how we got flush, don't we? That goes into the, like for example, the city of Sibley, it goes into the septic system. Now our septic system, the bacteria in the septic system may still inactivate a lot of that bacteria or a lot of that antibiotic. If we live out in the country, if we've got a properly functioning septic system, that'll take care of it. But there is a certain percentage of that antibiotic compound that is unchanged and ends up in the environment, okay? 25% of the antibiotics we use in this country are used in animal feed, okay? Now, I'm a farm boy. If we're gonna grow food for 8 billion people on this world, we need to do some things to increase the survivability of our livestock, okay? So I'm not saying one way or the other. But what happens to the antibiotics in the animals that get excreted unchanged? It gets spread out on the fields and it gets incorporated in other things. So I want you to hold that thought. We've got a lot of antibiotics in the environment, okay? It's not just the ones on the shelf in the pharmacy, okay? This is where we talk about, if you hear somebody talk about the golden age of antibiotics. If we go back here, you know, we've got the research that was going on. This is that salvarsan that I talked about. Here's the sulfa antibiotics, penicillin antibiotics that Dr. Fleming, in the 1940s, we start using it early in the 1940s. We start seeing resistance rate, but in here, this is what we call the golden age of antibiotics. In the 60s and 70s, we really started getting into trouble. You know, if anybody remembers back in the 1960s, in baby nurseries in the hospital, what was the fear? Polio. Well, there was polio, that's a virus. There was something else though. Staph infections in the nurseries in the hospitals, because a lot of the normal staph bacteria, and there's staph bacteria everywhere, and there's good staph bacteria on your skin, by the way, which we'll get into that. But anyway, we were getting it back when I was in training. Dr. Foster, remember in the ICU, Pseudomonas. Oh God, Pseudomonas. Oh man. You know, I see some other heads going like this. Some of the nurses that have a few zeros in their birthdays. But Pseudomonas, that was a big thing. And then we started getting into VRE, vancomycin resistant enterococcus. That was a big one, okay? And so we've got to keep coming up with new antibiotics all the time. There's a phrase we use in medicine when we give antibiotics and we say the bugs always win. In other words, eventually, the antibiotics that we've been using for decades eventually aren't really going to work at all. And we are seeing. So we're trying like crazy to come up with new antibiotics all the time. But we're kind of losing that race. Okay? Another little story about, you know, like I say, I'm kind of a history guy. To talk about a lot of the penicillin that we take gets excreted through our urine unchanged. During World War II in some of the army hospitals, when the soldiers would get wounded in battle and stuff, and a lot of them would get staph infections in those open wounds. You know, war's a dirty business. When they were giving IV penicillin to the soldiers in some of these wards, the soldiers that were getting penicillin, y'all remember pickling stuff? You got the crocks, you know, big porcelain crocks. Soldiers on penicillin had to go relieve themselves in the crocks. Because what they would do then is they would take that crock after it was full, purify that, filter it, draw the penicillin back out, put it back into an IV, and some other soldier would probably get some of that penicillin. Okay? And if you look at the doses of penicillin that were used at this time, probably about 120,000 units of penicillin per day was enough to take care of a staph infection. All right? It didn't take but 5 years where it took 500,000 units. Okay? What we use now, sometimes we will still, once in a while, if a kid's got a strep throat, we'll give them a penicillin shot. That's 1.2 to 2.4 million units. We've had to keep using more and more penicillin all the time. And that's for those bugs that aren't even totally all resistant. Okay? It's estimated, now antibiotics are good things. They may be too good of things, because it's been estimated that the antibiotic usage we've had in this last century has added 23 years to the average human's life expectancy worldwide. Okay? That's a big, antibiotics are game changers. Okay? But they've only been around less than 100 years. Okay? They cure life-saving infections, and they treat other less serious infections so they don't become serious. All right? So, antibiotics used to have a lot of bad side effects. Antibiotics can still have side effects. All right? We have good bacteria. We're finding out more and more of that. I thought about adding more of that into this talk today, but we could have been here 3 hours. We're finding out that we all have what we call a biome. Okay? We have beneficial bacteria on our skin, in our guts. Now we're finding out we even have it in our respiratory trees and other parts of our body that help us and protect us from other. Remember the movie The War of the Worlds? What ended up saving us from the alien invasion? The germs, the bacteria that the aliens were not used to. The bacteria that the human beings have been around for thousands of years, we've gotten used to. Okay? When the aliens came, they had no immune systems to deal with the bugs that we have. So our bodies have a beneficial relationship to certain types of bacteria. And sometimes when you take an antibiotic to get the bad bugs, you're going to kill off some good bugs. And so it's very common when you do that, it happens in the intestines, you can get diarrhea, nausea, vomiting, it can throw that off. You could be sensitive to the compound in the antibiotic. Sometimes you can get dizziness because certain antibiotics can affect our blood pressure, heart rate, and other things, just like other medicines can. If you're allergic, you can get a rash, or if it kills off beneficial bacteria on the skin, that may contribute to the rash. Yeast infections and other types of microbiotic infections occur on the heels of antibiotics. There are serious side effects. They aren't as common, fortunately. Again, the C. difficile infection, Clostridium difficile, comes with certain types of antibiotics, or if you've needed to be on high-dose antibiotics. Those are one of the super bugs, C. difficile, or C. diff we call it. I'm sure some of you are familiar with that. The VRE we have, all those things, they get developed resistance. And we see those bugs now, they're tougher to treat. Allergic reactions, sometimes if you can have what we call anaphylaxis. That's where your tongue can swell, your lips can swell and choke off your airway, and you can die. You can get vascular collapse. You get bad hives. We have in recent years found out that maybe some of the people who thought they were allergic to penicillin really weren't allergic to penicillin. They might have been allergic to something else because of how the penicillin was purified years ago. If you're on certain medications, antibiotics can interfere with that. Warfarin is a blood thinner. Vitamin K is very important in our clotting of our blood. Warfarin affects our vitamin K. Most of the vitamin K that we get in a day's time is made by bacteria in our intestines. And again, you take an antibiotic, you kill some of the good bacteria off that are making the vitamin K. Coumadin gets stronger because there's less vitamin K to work with, and your blood gets really thin. Conversely, there are a few antibiotics that can interfere with the action of Coumadin, can thicken your blood. So certain blood pressure medicines, certain antacids, NSAIDs like Aleve, ibuprofen, can all interact with antibiotics. It can make them more potent or less potent. But the big thing where we get into the antibiotic stewardship is the resistance, okay? It's a global problem. It's not just a problem here in the United States or Northwest Iowa. It's all over the place, okay? Because the bacteria get resistant and the antibiotics no longer work, okay? That was my whole thing about going through the history, is we've used them, we've overused them, and now we're reaping what we've sown. Okay? When should you not use antibiotics? Well, number one, influenza. Influenza is caused by a virus. Antibiotics won't help. Now, having said that, sometimes if you have influenza, you can develop a secondary bacterial infection. So sometimes if you have influenza and 3 weeks later you come in with a pneumonia, we may be more likely to treat you. All right? But there are some tests we do to see if you need an antibiotic. Common cold, runny nose, the sinus infections, which we're finding out a lot more sinus infections are caused by viruses than bacteria. And that's where I think we see a lot of the overuse of antibiotics is for respiratory type infections. That cold, that flu, that sore throat, that's not strep. Strep throat needs to be treated with antibiotics, okay? The main reason we treat strep throat is why? Making you sweat. Okay, that's fine. The main reason we treat strep throat is to prevent rheumatic fever, okay? Even the sore throat and strep throat a lot of times will go away in a few days. And you've got 10 days from the onset of the strep throat to start antibiotic treatment. So you could still, if you get a sore throat, you don't have to show up at the doctor the next day, okay? If you're not running a fever and you're not having a productive cough, you're not wheezing, you're not short of breath, you could probably treat symptomatically and wait that out, okay? Most instances of bronchitis, now when I was in training, if somebody had bronchitis, they had a productive cough, or run a little bit of fever, they got an antibiotic, right? Yep, that was acute bronchitis, it was an antibiotic, okay? We're finding out now that most of the instances of bronchitis are actually viral, okay? Now, if you're running a fever, high fever and that sort of thing, you probably should be checked out. If you're having shortness of breath, or if you're, have other constitutional symptoms with it, then you should at least be checked to see if you need an antibiotic. But if the tests show you don't really need an antibiotic, or the clinical signs show you don't, it's probably better that you don't. Because what we're finding out is, even in our lungs, we used to think our lung passages were sterile all the way down. Once you got past your voice box, we thought, well, there's no bacteria in our lungs, at least there shouldn't be. What we're finding out is that we have beneficial bugs even way down in our lungs. And those bugs interact with the mucus in our lungs to provide a protective barrier against infection. And some of those are bacteria. So if you get a viral bronchitis and our good bacteria are fighting against that, we give you an antibiotic, we're inhibiting your body's own biome from fighting off that virus infection, and we can actually make you sicker, or make the illness last longer, or predispose you to a more serious infection that's harder to treat later. So that's why many times we say, no, I don't think you should have an antibiotic this time. But doctor, I'm going on a cruise in 10 days and I want to make sure I'm not sick. Well, if I put you on an antibiotic, you may not be able to go on that cruise. Okay? All right? So you usually don't need antibiotics for certain ear infections. In fact, in Europe right now, if somebody a little baby comes in with an ear infection, unless they're toxic or have toxic symptoms like high fevers, not feeding well or whatever, a lot of times the doctors will wait 48 hours before they put the child on an antibiotic, just because a lot of those will get better on their own. And again, the sinus infections we're finding out, so sinusitis, bronchitis, and some of the ear infections. Now in the United States, we're still using antibiotics a little bit more for the ear infections. But sinus infections and bronchitis, a lot of times, it may be better not to be on the antibiotic. So, so that's why it's still probably not a bad idea to get checked. But if you see a provider and they tell you not take an antibiotic, please don't be mad at them. Go see somebody else down the road the next day to try to get an antibiotic. So, like I said before, because of this overuse that we've had, that's one of the big problems. So, how do you help us with that? How do you participate in antibiotic stewardship? Okay? Number one, take your antibiotics exactly as your provider instructs. I will tell you, nothing cranks me off more than to have somebody come in and said, well, yeah, you know, when I was here 6 months ago and I got this antibiotic for this infection, I had 3 left over, so I started taking them yesterday.
Oops.
No, you're promoting your resistance, okay? All right? Your brother-in-law Joe comes over and you say, well, I've got a couple penicillin left over from when I had sore throat, just go ahead and take it. Don't do that, please. You're contributing to antibiotic resistance. So if you're given a prescription for an antibiotic for 10 days, please take it for 10 days. If it's for 3 days, take them until they're gone. In fact, most of the time, I think you look, the pharmacist puts a sticker on, please take this medicine until it's gone. Okay? So take the antibiotic. Don't go to Mexico and buy a 1,000-count bottle of amoxicillin and take it. All right? I'm serious. When I lived in another community, I had a patient that was in the Naval Reserves, and he would go down to San Diego every year for training. While he was in San Diego, he would run across into Mexico and buy a 1,000-count bottle of amoxicillin. First of all, I would dare to bet you the amount of amoxicillin in those capsules was not what the label said, okay? It was probably less than half of what was in there. And that's another thing, because if you don't take as much of the antibiotic as you should, you're going to promote resistance. If you don't take it as long as you should, you'll promote resistance. And so he was doing that, and I encouraged him not to do that, because what would happen is his kids would get a sore throat. He'd give them penicillin for a day or two. He'd come in, he'd bring the kids in. It would look like strep, so we'd get a throat culture, and the throat culture was negative. Because by giving his kids a day or two of that amoxicillin, he was throwing our test off. Okay? I can't advise you properly on what to do for your condition if my tests aren't reliable. And so when you take a day or two antibiotic and then come to the doctor, that could throw the tests off. And we may make a misdiagnosis based on not taking the medicines properly. So and that's not just true for antibiotics, through other medicines, but that's beyond the scope of this. And again, don't save your antibiotics for a later time. Do that, I'm going to find the biggest needle in the clinic. You're going to get a shot, okay? Only use the specific antibiotics because not all antibiotics are the same, okay? For example, in the case of strep throat, if you take a sulfa antibiotic, you could get a strep super infection, and you can die from that, okay? There are specific antibiotics for specific bugs, okay? I've gone to school for that. I have a diploma for that. They even gave me a stethoscope, okay? We know what to do about that. We know the right antibiotics to pick. So please do that. Okay? Don't take a medicine for somebody else's medicine, or don't give your medicine to somebody else. They're tailored for you. Sometimes the dose of the medicine, if somebody's kidneys are slower, we will adjust the dose. If you have allergies, in fact, there may be, even though you may not be allergic to the medicine, you may be allergic to one of the known carriers that we put in the pill to make the medicine more absorbable, okay? Because we know your allergy history and all that sort of thing, so don't do that, please, okay? And then safely throw away unused medicine. Usually, you'll get the exact amount that you need and you shouldn't have any left over. But if you have any medicine left over, the FDA actually has a flush list and a non-flush list. Most antibiotics, I mean, hey, I've done it. In the past, what do we do with the extra medicines? Throw them in the toilet, okay? You're not supposed to do that with her because it wasn't that long ago, I think downstream in the Mississippi River, they did some testing and they found significant amounts of tricyclic antidepressants in the river water, okay? And again, it's not just antibiotics that are in our environment. Some of, nowadays there's a pamphlet, if you've got medicines you shouldn't flush, talk about mixing them with a little cat litter or coffee grounds, put them in a little Ziploc bag and throw them in the trash, okay? But I would contact pharmacy. Your pharmacist will know what to do with those medicines, whether you can safely flush them or whether you should dispose of them in other means. Some of the medicines, there are certain places where they've got take-back programs, so they will take your medicines. Some of them should be incinerated and that sort of thing. I put that up there so I just don't make this stuff up. I actually do a little reading and research on that. I think right by your, where you're sitting, there's a smaller version of something that looks somewhat like this, okay? Hopefully, if you have a respiratory infection or a virus, this guideline can kind of help you decide whether or not you really need to have something that requires an antibiotic or not, okay? So, common cold, sniffly, runny nose, no fever, that sort of thing, nope. Sore throats, mostly not, unless they're strep. And I will tell you, most adults don't get strep, but some of them do. And usually strep causes a fever. Strep is what we call a really pyrogenic bacteria. It generates fever. It generates temperature. Pyro, fire, it makes you hot, okay? So strep throat's a different animal. If you're running high fever with a sore throat, then it more likely you probably should get checked. COVID-19, now we do have, again, other antivirals for that. This talk, again, mostly for antibacterial, but regular antibiotics don't. Early on in COVID, before we really knew what we needed to know, we did give azithromycin and some other things early on because of how they interacted in the lung and stuff, so there were antibiotics used, but not anymore. Influenza, we've got antiviral medicines, but antibiotics for bacteria do not affect that, okay? For the most part, bronchitis, probably not. But if you're running a fever, if you're bringing up a pretty ugly stuff, then you might want to at least get checked. Middle ear infections, maybe. Sinus infections, maybe, but we're thinking nowadays, again, more not. Strep throat, definitely. Whooping cough, definitely. Things like cellulitis, infections of, if you got a red arm, you got poked or scratched and you got a red arm, erysipelas, stuff like that, we still give antibiotics for that. So the important thing is, we don't want to use antibiotics. You want to take them as prescribed. Don't save them for a rainy day, and don't share them, okay? You can share chocolate chip cookies, but not antibiotics. All right? Any questions? Yes?
What are your thoughts about taking probiotics when you're taking antibiotics?
There is a group of researchers who think that most people probably should take it anytime you're on an antibiotic, you should take probiotic. Now that's a minority opinion. Most of the time, most of the researchers say, look, if you're going to be on an antibiotic less than 10 days, you probably don't need to. That's not long enough to really monkey up. But sometimes if you got a more severe infection, that sort of thing, where you're on an antibiotic, You know, sometimes with the acute bacterial sinusitis, we do use antibiotics for 2 to 3 weeks. If that's the case, you probably should use a probiotic. Now, the problem is, when do you take the probiotic? Do you start it right away? That's part of where the controversy is. Do you start the probiotic on day 1 when you start the other antibiotic? We're not so sure about that, because the antibiotic you're taking may kill some of that probiotic too. Do you start it, if you're going to be on it 10 days, start it halfway? Or do you start it as soon as you're completed? In what I've read, in my opinion, if you're going to be on an antibiotic, and if you've had a history of C. diff, or if you get diarrhea really easy on antibiotics, my recommendation is if you start the diarrhea, take the probiotic. Or if you really feel you need a probiotic, I would take that probiotic after you're done with the antibiotic. That's what I think. Have you read anything different than that, Dr. Foster? Okay. But if you feel you need to take a probiotic, I would do it toward the end of the antibiotic or right after you're done. You're going to get more bang for the buck out of that. Yep. Good question. Yes?
Why do people go to Mexico for arthritis medicine? I never did understand that one. Money?
Money. It's cheaper. Okay? Everything's more expensive in the United States, right? And that's, when it comes to medications, part of that is for a reason. First of all, not all of the medicines are made here, so there's a shipping cost. Number 2, the medicines are more regulated here, okay? All right? You're not buying antibiotics at the hardware store. You're getting them from a pharmacy. The pharmacy is regulated. There's a lot of counterfeiting in Mexico. But they're very, very good at copying the packaging, and they're very, very good. For example, the last episode I had with a situation like this, I had a guy who had a heart attack, his cholesterol needed to be really low, and he was on Lipitor, all right? He was tolerating Lipitor, he had Lipitor. Went on a trip to Mexico, he came back a few months later, had his cholesterol checked, and it's 360, all right? Which is what it was before. On the Lipitor, he was like 150, okay? His cholesterol was 360. I said, when did you stop taking your Lipitor? And he looks at me like I'm not very smart. And he says, I still take my Lipitor. Oh yeah? I said, really? I said, well, your pharmacy must have changed wholesale or something. Is it the same brand as what you took before? Is it a different generic or something? Because if that's the case, then we got to get a recall started or something. Well, he kind of looked at the floor and he said, no, I bought my bottle from Mexico. I said, well, I can guarantee there's no Lipitor in those pills that you bought from Mexico that say they're Lipitor. Okay? That happens a lot.
I have a neighbor that did the arthritis one. He went there every year. And I thought, wow, why do you go there? Why don't you just go there?
I will tell you, a relative of mine had COPD, went down to Mexico and bought his breathing pills. All right? And I said, well, it's making you feel better, but there's going to be, because I'm sure there's cortisone in there. Okay? It's making you feel better today, but there's going to be a day of reckoning. He insisted there was no cortisone in there, and he showed me the packet. He said, these have been analyzed, et cetera, et cetera. Well, it said right on the back, beta-methazone. Okay? So yeah, steroids can make anybody feel better for a while, but there's a lot of baggage with that. That rose has a lot of thorns. And so, yeah, he ended up dying of osteoporosis and multiple blood clots in the lungs. Yeah. So the thing is, be very, very, very careful. In fact, we got a letter, it was a few years ago, it was very popular for people to get medicines from Canada. Now I say Canada is much better than Mexico.
Yeah.
What was happening is doctors had to do extra paperwork for people to get medicine from Canada. We got a letter from the state of Iowa, from the medical board saying, if we find out your help, because the stuff from Canada is still not FDA approved, okay? And they said, if we find out that you're helping people, hey, if I get you a prescription, where you get it filled is kind of your business. Mm-hmm. But if I have to do extra paper and they find out I'm helping you, the state of Iowa said, you're taking your license away, okay? So if you see me bagging groceries at the grocery store, it's probably because I help somebody get medicines from Canada.
Oh, jeez.
And I'm not saying that happens with every medicine, every time, but it happens enough where there's a lot of warnings about not buying stuff in Mexico.
I know, it's cheap cash.
Right. So is the lunch good?
Yeah.
All right, very good. Very good. What? Oh, yes.
I get a cough terrible when I get a cold. I have whooping cough when I was little.
So you probably have some bronchiectasis.
So what do you do? Or what should you do if you?
Well, antibiotics may not necessarily improve that faster, but there are other things there are medicines now that are non-steroid type medicines that help get inflammation out of the lungs. But that's one of the big things that, when I was in training, I saw people that had whooping cough back in the 1920s and 30s. Whooping cough was really bad before we started immunizing, pertussis. There are a lot of people that had bronchiectasis that had permanent lung damage. So that's one thing about whooping cough. If you get it when you're younger, there's a lot of chance you cause permanent lung damage. So when you get just an upper respiratory infection, it's more of an insult to your body. But there are other things to do it, but some people will, in fact, the pulmonologists tell us nowadays, even with a cold, even after the infection's gone, you can cough for 6 to 8 weeks. That's normal, expected, don't worry, now, if the coughing is causing you to see stars when you're driving down the road, we probably better do something about it. Or if the coughing's keeping you awake at night, we probably better do something about it. But we've got some other tricks and things that we can, it doesn't, nothing works for everybody, but there are other things that we can do. Antibiotics aren't necessarily the answer for that. Yes?
What about over-the-counter medications? Do they, like say you have sinusitis or whatever, and you get Mucinex or whatever, is this something that's fighting against your bacteria or?
Mucinex would not be. Most of the stuff you get over the counter, Mucinex is not gonna, what Mucinex is gonna do is thin your mucus so it can move better. And that's one of the ways our body protects itself is constant moving of mucus, okay? If you go down to a creek and the water's flowing nice, it's nice and clear, isn't it? You go to a stagnant pool of water and there's all green stuff floating on the top. Same way with our bodies. We've got a constant low-grade production of mucus. That's why with sinusitis, it's not so much the bug, it's the garden it grows in. You get a virus, things swell up, the flow changes, and things build up, and then boom, you've got symptoms. The thing about Mucinex is it's going to thin that mucus so you can promote things moving. If you're doing a lot of sneezing, then an antihistamine would be maybe in order. If it's not allergic, we try to avoid people taking an antihistamine. Okay, an antihistamine would be like Benadryl, Claritin, Zyrtec, those types of things. Because antihistamines can dry up runny noses from allergies, but the other thing they can thicken the secretions. So when it comes to a sinus type thing like that or a regular cold, we do kind of tend to recommend people avoid the antihistamines unless we know there's an allergic component to it. Decongestants, even though they're a little harder to get now because of the meth thing and stuff like that, decongestants can help open things up to get things moving as well. But a very important concept here is if you've got something like that, mucha agua, okay? Drink lots of water because your body uses water to help in that protection. It's one of the things. So drink lots of fluids, okay? Decongestants are better than antihistamines. Mucinex you could probably use without much concern or regard. But most of the stuff over the counter is not going to interfere very much. The problem that we get with some of the stuff over the counter, especially some of the over the counter nasal sprays, when you use those, when that medicine wears off, you get a rebound congestion. And one of the things we see, that's why it says on the label to only use it for 3 days, because if you use those nasal spray, now I'm talking decongestant, okay? I'm not talking Flonase, that's for allergies, okay? But the decongestants, the things like Afrin and neosynephrine and that sort of thing, you gotta be careful with. Because if you overuse that, that causes vasoconstriction, and eventually the lining of your nose is gonna get poor oxygen because not enough blood flow. And you get a condition that we call rhinitis medicamentosa. That's a big 2-bit word saying that you just ruined the lining of your nose. And a lot of people have to have submucous resection, and that's not a very nice surgery to have. So the decongestants you gotta be a little careful with, plus decongestants they're a stimulant, so you gotta watch, if you've got high blood pressure, if you take a decongestant, watch your blood pressure, heart rate, and if you've got a propensity for stroke or seizures, you gotta be real careful also. Yep.
Question.
Yes.
I had C. diff several years ago,
Yep.
and I'm terrified to take antibiotics. So I try never to take them because I know.
Good for you.
Yeah, I try. But should I have to take them? Are probiotics good to take after you have a bout of antibiotics? Will that help?
The American Gastroenterological Association would say yes.
Okay.
In fact, there is a particular probiotic they recommend for people that have had C. diff. It's called Saccharomycosis boulardii.
Okay.
It's a specific type of lactobacillus that seems to work better for people.
Okay.
It's called Florastor, I believe. But yes, and the interesting thing about it is, if you take a lot of people that have had C. diff after an antibiotic, most of the people had C. diff in their intestines before they took the antibiotic. But what happened is their good bacteria kept the C. diff in check. And what happened is when they took the antibiotic for whatever reason, now there are certain types of antibiotics that get you more prone to C. diff. But what happens is, we think anyway, that the antibiotic you take suppresses your good bacteria enough where it lets yeah. You know, think about a lawn. If you got a nice plush lawn, your grass is nice and thick, pretty hard for the dandelions to get started, isn't it? What happens if you gotta run a pipe through your lawn and you dig it up? What happens? You got the weeds there. Same thing, if we think of like the grass is the good bacteria in our gut, if we do something to dig that up by taking an antibiotic, then the dandelions are C. diff. We'll think the C. diff's like the dandelions, that'll get started. And if you get enough C. diff, because it's not the presence of the bacteria of the C. diff, it's the toxin it makes. There's a poison that bacteria makes that causes you to get the symptoms. So that's why when we test for C. diff, we test for the toxin, not the antibiotic, because not the bacteria, because a lot of people normally have C. diff in their colon, and it's normal for them. And a little bit's okay. Too much is not enough. Or too much is not good. So yeah, I think probably in this situation, if somebody's had C. diff in the past, you're probably somebody who definitely should consider taking a probiotic with the antibiotic.
Do I take antibiotics?
Thank you, Dr. Kosters.
Shut it off.
Thank you. That was a great presentation.
Yes, it was.
Wonderful. So much information. So I just had a couple things to follow up with. This March, if you need a colonoscopy, if you schedule it during the month of March, you will get a 1-month membership to our wellness center. So if that's something you guys are interested in, call the clinic, schedule an appointment, see if your primary says that that's a good option for you. And then also don't miss our next Lunch and Learn, which is February 29th. Fill out the slips and then put them in that blue basket on your way out, and we look forward to seeing you. Thank you guys for coming.
Thank you.